Okay. I'm Teresa Bernal. I've worked at the Institute here for 38 years now, in multiple capacities, um, and am interested in this whole process because I've done most of my career in forensic psych, and so have been kind of smack dab in the middle of this entire process. So first, I'd like to say I really appreciate the opportunity to even give some feedback, and appreciate that you guys came down. There is absolutely no way to say everything that needs to be said in 5 minutes. So I said, that's nice, thanks for the opportunity, but it's not, really going to be sufficient. So I typed this thing that has recommendations or, thoughts, recommendations that people can look at, okay? The upshot of the whole thing is essentially this. That, I saw this lovely press release about all the additional beds. That is a very powerful thing. It will be a very good thing. I was around when there were about 1,000 beds, and saw it kind of whittle down to 300 and something, and then it's like bounced back some. We need the beds, okay, so that much is clear. However, we can almost do the job right now with this capacity of beds without a wait list if we had anywhere we could put people when they left here. And so there is a huge lack of community level resources for diversion programs, for substance abuse problems. We sort out here at the Institute with a lot of these criminal orders, a lot of people who that may look psychotic but really are just severely strung out on meth and coke, and they are psychotic at the time, however not permanently psychotic. And what I find interesting is on the wait list, sometimes people wait for 200 days to come in. By the time we get them, they're fine because it was drug induced, and so they're pretty well stabilized. So the whole system has become overrun because of drug issues, because of huge changes in the mental health center system. In the mid-90s, they were state-run, and prior to that, my whole career prior to that. And when it went privatized, they completely changed access to services criteria. So the private agencies, you have to have insurance or Medicaid. We'll do some stuff for the indigent on a wait list basis and blah, blah, blah. Okay, so people can't get Medicaid if they're homeless. If you don't have a permanent address, you can't get Medicaid. Okay, so needless to say, that means they have no access to services. When I was around for the first part of my career, they had access to services. And we admitted more admissions. We had like 1,500 admissions a year back in the late 90s. And we had more admissions, but the admissions were civil. They were like 95% from the civil, mental health center referral base. They were not from the criminal base. And almost no one arrested them because they could take them to a mental health center and get them M1'd into the hospital, okay? And so now they all come, 100% are coming through the criminal justice system. So that is overloading drastically the entire, multiple systems instead of just a mental health system. So I basically have been for years saying we need state-run placement beds in the community. We need state-run nursing home level, group home level, assisted care facility level, state-run. And it is incredibly dumb not to do it because it would be a lot cheaper than inpatient stay here. And we have about 80 to 100 people in this hospital right this minute that we could put out if we could put them into a state-run facility that can't say no. Okay, private facilities say no. Our people have got horrendous histories. They have multiple placement failures, and some of them have multiple violent crimes. Everybody can say no if it's privately run, and frankly, I would. Okay, I mean, I'd say, oh, he did what? He killed his roommate in a nursing home. Well, maybe, no. Okay. State-run facilities, we could do risk assessments here. We would have a good bunch of information to give the people. We could step them down, but it would also be immensely cheaper. There would be all kinds of efficiencies, and we could also get half of it paid for through the federal funding. We could get federal funding for long-term Medicare, Medicaid, and I've talked to the benefits specialists here. They have said, yes, you could definitely get them qualified, where we could still bill or ask, get their long-term Medicaid monies that would have gone to another private assisted care facility. So it's also that much cheaper it's cost effective. So that's what we need. And that's the upshot of this whole thing. And I'll just leave this here,
Thank you so
and you
much.
folks can, yeah.
Thanks, Teresa. And then I did not tell her to say.
I was
any
gonna
of
say.
those.
I didn't
Impaired.
Just great minds think alike. That's all.
They really didn't. They really didn't. In fact, it's really interesting because I said, I don't know how the behavioral task force was selected. I was very disappointed, frankly, that a lot of people from SIMHIP were not on it, particularly this subcommittee task force for competency, because hello, we've been battling it for 40 years, and we've been in the middle of it, and we have managed it, and we've actually done a pretty amazing job. And the current consent decrees and stuff are mandating us to sort of like fix things for all kinds of other systems that CDHS should not be fully responsible for. It's kind of beyond ridiculous. But I do think that state-run placement beds and diversion programs and step-down programs are absolutely going to be mandatory, because private sector is not going to voluntarily take it on. They're just not. It's not a big profit margin, but it is a big public safety thing. So I think it'd be in everybody's better interest. Anyway.
And thank you, Brandon. And I will just stress, we had so many people from SIMHIP and Fort Logan apply to be on the task force.
Yeah.
And with only 100 spots, we just couldn't do it and get all the community members engaged.
Of course.
So you're always welcome to come, to listen in. There's always a public testimony, so people have an opportunity to talk at all of them.
Yes.
There's lots of ways for people to get, and that's why we're down here today. We'll be at
Yes.
Fort Logan, and
Yes.
always open to hearing ideas.
Yes, I was very glad to see you would be down here today, and I was very glad that you are. I think, I will say, I think there's been a commendable effort to get input and feedback from people. But in terms of process and in terms of understanding which interventions might most greatly impact some of these processes for the competency, there still should have been a couple more people from here, maybe perhaps on the task force. Anyway.
I welcome you to attend any of the meetings,
Okay, all right,
either by Zoom or in person.
okay. All right, well, thank you.
Yeah,
Appreciate
thank
it.
you.
Thank
right.
you so much.
Thanks.